And I'd like to move on and introduce our last speaker. Dr. Onyema Ogbuagu, otherwise known as Dr. O, is an associate professor of medicine and director of the HIV Clinical Trials Program of the Yale AIDS Program, section of infectious diseases of the Yale School of Medicine. He's also the Yale Principal Investigator on multiple investigational, therapeutic, and preventive clinical trials for COVID-19. And he will speak to the current status of COVID-19 treatment options for mild, moderate, and severe disease. Thank you, and over to you, Dr. O.
Hello, everyone, and thank you for that gracious introduction. It's always fun to be the last speaker because I'm probably between you and your lunch if you're West Coast time, and if you're East Coast time, probably between you and your next webinar. So today we'll be focusing on the current status of the COVID-19 treatment options for mild, moderate, and severe disease. It's impossible to be exhaustive regarding the treatment options that are available, and I've chosen to focus on a few as I'll highlight as we go on. My disclosures are as shown. So our learning objectives today would to discuss currently authorized or approved COVID-19 treatments. I'm going to really focus on remdesivir and remdesivir combination approaches, as well as the monoclonal antibodies. Some of these had interesting data at CROI, and so that would be the focus of the updates. I'll try to highlight as we go through the slides what I consider to be data gaps with the treatment options that I highlight, and end with discussing, some of the exciting, or at least an exciting or promising COVID-19 treatment option that we heard about recently. So let's go to an audience response question. So I guess I'll try to read them out, which gives you time to respond. So the Act 1 trials showed the receipt of remdesivir for less than 5 days following symptom onset, compared to those who received it greater than 5 days symptom onset, was associated with improved outcomes. Mechanism of action of remdesivir is via inhibition of SARS-CoV-2-like protease. Oh, I see that the first question wasn't complete, but it's improved clinical status. So just add that to your thought process. C, remdesivir was associated with higher rates of incidence AKI in patients with moderate COVID in the simple moderate study. And the last option is in the simple moderate study, participants in the 10-day arm of remdesivir did not have improved clinical status compared to placebo recipients. Okay, and we have the results. So I see that half of you chose that the Act 1 trial had showed a benefit. That was a cutoff for 5 days from symptom onset, and then we have a smattering of other responses. So you will, as we go through the presentations, we should address those. So I just want to start by the NIH COVID-19 Treatment Guidelines. These are living guidelines that respond to new data as they emerged, including data that hasn't yet been published, as has become the norm in the COVID-19 era, but with the caveats that they haven't always been peer-reviewed. It's a little disheartening that, 1 year into the pandemic, that this list isn't long, especially just given the flurry of activity around clinical trials, the real global effort to try to identify treatments or therapies that work. In the antiviral spectrum, we see that remdesivir remains the one agent that's authorized and now approved, and per the NIH recommendations for stratified for inpatients by their oxygen requirements. So for those who require oxygen supplementation all the way from nasal cannula all the way through non-invasive positive pressure ventilation, there's a requirement to use that, and it's unclear that there may be some benefit for those who are hospitalized. For the monoclonal antibodies, they're listed, those that are single agents like bamla, nivomab, and combination therapies. We're going to go through some of the studies for these agents. Again, depending on the quality of information, plus minus insufficient evidence for outpatient therapy, we do know that these agents have really shown benefit more in the outpatient setting, and either futility and in some cases harms for inpatients. Combination BAM azevimab has been recommended for used for outpatients with mild to moderate disease. I'm not going to discuss the immune modulators, dexamethasone. We know the recovery trial data, as well as tocilizumab, which has really had a lot of mixed data to date. And happy to take questions around those in the Q&A. So let's start with the Remdesivir studies. So this was the Act 1 NIH trial that was published in the New England Journal of Medicine, where Remdesivir, it was a multinational trial of 10 days of Remdesivir, not the duration, versus placebo in patients who were hospitalized with COVID-19. There was a spread of patients with both, moderate, severe, mild disease. This was shown. So in this study, we saw that the primary endpoint was the recovery time, and the median recovery time was 10 days for Remdesivir compared to 15 days for placebo. So there's a 5-day shortening of median time to recovery, and that was clinically significant. In that study, there was found there was no effect on mortality observed. As most of us know. When subgroup analyses were done, there was an interesting difference by time. So for those who had symptom duration less than 10 days, they had a statistically significant relative recovery ratio, as well as younger individuals, 18 to 40, as well as those who were receiving oxygen. Then we also saw subsequent data on the simple studies. So the simple studies, there was a simple severe study and the simple moderate study. The simple moderate study was reported in JAMA. And remember, the simple moderate study was the multinational trial that looked at 5 days of Remdesivir against 10 days of Remdesivir compared to standard of care, so 3 arms. And these were in patients who are hospitalized with moderate COVID, as defined as having an oxygen saturation above 94%. So these were not individuals on oxygen. And so the study found that those who were in the 5-day arm did better than standard of care for clinical status distribution at day 11, which was a primary endpoint. This difference was not seen in the 10-day arm. They actually found an increased rate of adverse events in the 10-day Remdesivir arm versus standard of care. To the right, you see the distribution based on the ordinal scale that most of us are used to, and what it looked like in standard of care compared to the 5-day and the 10-day arm. So I think some of the questions from a clinical standpoint are that we've seen that Remdesivir can result in improved clinical outcomes in some of these well-designed clinical trials. However, we know that they really haven't shown impact on mortality. And I think that, based on some of these studies, there's still a lot of questions about, 2 outliers in the spectrum of disease, including those who have much more milder forms of disease who don't require oxygen. So those with the milder forms of COVID, including those who are outpatients. There's questions around what's the optimal timing to optimize the benefits from Remdesivir. Again, the 10-day cutoff from the NIH trial, but could there be even greater benefit for utilizing the drug in shorter periods? And so those are very, very open data gaps for Remdesivir. Now, we also know that Remdesivir has been studied in combination with immunomodulators, recognizing that, the paradigm of the pathogenesis model that we all are aware of, with a viral phase and then a dysregulated immune or cytokine storm phase. And so, carefully selecting out for patients that would benefit from a dual modality antiviral immunomodulator therapy has been a source of intense and investigation on many fronts. So this was one of such studies with Remdesivir and baricitinib, the Act 2 trial that was published in the New England Journal of Medicine not too long ago. This was a multinational study of hospitalized patients with moderate to severe COVID. In this study, people received either Remdesivir or Remdesivir, 10 days of Remdesivir, plus baricitinib given oral 14 days, or placebo. Steroid use was included in this study, very, very important to mention. So the results in this study were that they found that the time to recovery was shortened by 1 day in those who got the combination therapy as against those who got, 8 days compared to those who just got remdesivir alone. And when they looked at clinical improvement, there was a 30% higher odds by day 15 for those who received dual therapy. Now, if you look at the figure to the right, you see the subgroup analysis. And if you look at the bottom part of the table, you can see that when they looked at disease severity, it appeared that those who had more severe disease on presentation tended to have greater benefit with regards to recovery, and also those who had an ordinal 6 at study entry. So these were people who were requiring high flow oxygen and non-invasive positive pressure ventilation, defined as a subset. Interestingly, they found newer use of oxygen and mechanical ventilation tended to occur less in those who got baricitinib. Again, in this study, there was no mortality benefit, but with the caveat that the study wasn't powered for these individuals. Some of the concerns about using baricitinib would be the risk of, secondary infections, but that signal was not observed in this clinical trial, which was reassuring. And just also to mention that steroid use was excluded. So this was really an important consideration with regards to potential experience in the clinical trials with using what is now a standard of care in most of our real world patients. So here's some of the data from CROI, and I'm going to present 2 different abstracts that were presented that really talk about, in some ways off-label use of remdesivir, but start to provide very important data that go beyond, populations that the drug is approved for. So this was one study from Baylor by Flor Munoz. This was just really describing outcomes in an open-label single-arm study of remdesivir in children aged all the way through, 28 days, all through less than 18 years of age. To be eligible for this study, you had to be hospitalized, you had to have laboratory confirmed SARS-CoV-2 infection, and they had different GFR cutoffs depending on the age of the child. Also kept liver function test abnormalities less than 5 times upper limit of normal, and you could not be receiving antivirals for SARS-CoV-2. Overall, the study found, regarding safety, that remdesivir was well tolerated in majority of the participants. There were grade 3 or 4 laboratory abnormalities that were reported in half of these individuals, and some of these were decreased hemoglobin, decreased GFR, deranged coagulation parameters, and hyperglycemia. I think we all know, having cared for COVID-19 patients, that, many of these laboratory abnormalities could occur in hospitalized patients and may not always be attributable to treatments, as you can imagine. There was no comparator arm here, but just instructive to see the distribution of the clinical status in the lower figure. And as of the day 10, they had significant amounts of discharging, as at the last assessment, about 82% of those children are discharged. But there were 11% of the participants unfortunately succumbed to their illness. So this starts to add some data. There were only about 27 or so children in this study, so not a large study, but at least starts to provide some important data as to the safety of using the medications in younger children. Another CROI abstract focused on acute kidney injury in participants with moderate COVID-19 for those treated with remdesivir as their standard of care. I'm not going to mention the author, the presenter. So the background here is that we know that remdesivir is approved for hospitalized patients aged greater than 12 years, and remdesivir and in the excipient cyclodextrin. So that's one of the concerns that they're renally cleared. And so using them in people with severely reduced renal function is a concern. And that has informed, the FDA approval label, which says you really should not be using it in individuals who have a estimated GFR less than 30 ml per minute. So the objective here on this post-hoc analysis of the simple moderate study was to look at people on the 5-day and 10-day arm as a composite compared to standard of care arm to see if it was associated with acute kidney injury in hospitalized patients who had moderate COVID-19. So in this analysis, they really assessed for acute kidney injury events by stage, which corresponded to degree of severity of acute kidney injury. Overall, they found that of the 822 patients in the Remdesivir arm, as against the 183 participants, that there was no acute, there was less acute kidney injury in the Remdesivir arm compared to standard of care. Majority of these events were stage 1, so very milder forms of acute kidney injury. However, it was reassuring to see that there was no signal of worsening of new AKI among individuals who received Remdesivir. This is a post hoc analysis, as you can imagine. There were randomized and non-randomized patients who were included in the Remdesivir arm because there was an open label extension in the study. And, even with those caveats, but I think this at least suggests that, there wasn't any, that there was at least a favorable issue around the risk of developing AKI. Based on these data, there's a trial of Remdesivir in people with COVID-19 and severe renal impairment is planned, and we cannot wait to see what that data shows. So here's the response to the initial question we asked. So the Act 1 trial, I think we've now seen that the cutoff was actually 10 days and not 5 days. The mechanism of action of Remdesivir is via inhibition of the RNA-dependent RNA polymerase, so that's not accurate. Remdesivir was not associated with higher rates of incident AKI in the post-hoc analysis of moderate COVID-19. And then we did show that in the moderate study that the 5-day arm seemed to show improved clinical status, but we did not find that in the 10-day arm compared to placebo. So that's the right response. Okay, so let's do another audience response question, and it's projected on your screen, and I'm happy to read that. So bambalanivam, also known as BAM, shows excellent in vitro activity against B117 and B1426 California origin variants. Hospitalized patients who received BAM in active trials showed higher recovery rate ratio compared to placebo. Azevimab and devimap bind to overlapping epitopes of SARS-CoV-2 spike protein receptor binding domain, and then outpatient studies of SARS-CoV-2 mAbs have shown inconsistent relationships between viral load trajectories, decay trajectories, and clinical outcomes. Okay, we're going to show the results. Perfect. So good. I think you've said good questions when there's a good spread between all the options you offer. And so it looks like the top two responses chosen were the hospitalized patients who received BAM showed higher recovery rate ratio compared to placebo, and that outpatient studies have shown inconsistent relationships. So watch out for that as we discuss the remaining slides. So let's start with bambalanivam, LYCOV555, which was studied in mild to moderate patients. This was a study reported in the New England Journal of Medicine, and this was the phase 2 study that looked at outpatients who had recent mild to moderate COVID-19. So they had to have tests within 3 days of getting the infusion, so kind of really short period before they're exposed to drug. And at 70% of these had at least one risk factor of progression to severe COVID. We do know that BAM targets the receptor binding domain of this spike protein. So if you look at the table at the bottom, you can see just the spread that about 100, received different, 3 different doses of bambalanivam, which was, 700 milligrams, 2,800, 7,000, and 143 were enrolled on site to placebo with. But the data that I'll present would be an interim analysis. The primary endpoint was virologic, so the change from baseline to day 11 in the SARS-CoV-2 viral load, and an important clinically meaningful endpoints around safety, severity of symptoms, risk of hospitalization. Remember, these were outpatients, so risk of an ED visit hospitalization. So what the study found, confusingly, was that if you looked at the 3 different doses of bambalanivam, only one dose range looked different than placebo at day 11. This slide shows, the image shows the viral load at day 7, and you can clearly see that on the horizontal axis is the cycle threshold with lower numbers, meaning higher viral loads, and the cumulative probability of having the virus detected viral load, but is on the vertical axis numeric wise. And so it's interesting that only those in the 2800 group definitely had significantly lower viral loads than those in the placebo group. Now, when it came to clinical outcomes, one of the key secondary outcomes, as you can imagine, was hospitalization. So the incidence in the placebo arm was about 6.3%, and you see that the hospitalization rates range from 1% to 2% across the different doses of bambalanivam that were received, with a pooled hospitalization incidence rate of 1.6%. On subgroup analysis, they found that the differences in hospitalization rates were particularly significant for those who were elderly, greater than age 65, and BMI. I know that some hospital protocols, that are allowing the use of bambalanivam or implementing the use of bambalanivam for outpatients have then, picked on this data and focused on those characteristics as defining what patient populations they want to use it in. There was no serious adverse event in those who received bambalanivam, which was reassuring. This is one of the studies that started to where you had a disconnect between what happened with the viral load trajectories over time and what the clinical outcomes were, symptom severity, and which is at least interesting as to what the proper and endpoint should be for these kinds of studies. Should we be looking at viral load decay, obviously clinical outcomes like risk of hospitalization, disease progression is important, or both? And the next study to present, this was at CROI. So this is bambalanivam and azevimab, combination monoclonal antibodies. In the BLAZE-1, this was again a study in mild to moderate patients presented at CROI. So bambalanivam and azevimab are monoclonal antibodies for, again, targeting the spike protein for treatment. And this was evaluated for the treatment of COVID-19 in high-risk ambulatory patients. It's an ongoing trial. It included patients, again, with mild to moderate COVID who were diagnosed early. That seems to be the approach within 3 days of a positive test. They included people above the age of 12 and with at least one risk factor for severe disease. So similar to the BAM trial we showed. In this study, there was a single infusion of 2,800 milligrams of the monoclonal antibody combination versus placebo. Thought you may want to know what the breakdown of the participants were. It was about 52% females or so, about a third were elderly, and the mean BMI was in the obese spectrum at 33 to 34. Remember that they had at least one risk factor for severe disease. In this study, majority had milder forms of COVID. So in this study, they found that the risk of COVID-19 related hospitalization, or the composite of COVID-19 hospitalization, any cause death by day 29 was reduced by 70% in those who received the combination monoclonal antibody. It's both shown in the table above and also in the figure below. And a lot of the events appear to occur early, as you can see, in both the BAM arm and the placebo arm. So just to highlight that. Interestingly, in that study, at that period of observation, there was no deaths in patients who received the combination monoclonal antibodies, as against 10 in those who received placebo. Unlike the prior study, viral loads were significantly lower in people who received the combination monoclonal antibody approach here. And here's another monoclonal antibody. This is karkyr and devimap, and this is for mild to moderate COVID-19, the so-called REGEN-COV2. Again, these are monoclonal antibodies directed against RBD, non-overlapping sites in the RBD. In this study, they've enrolled 799 patients. It's a double-blind, randomized, placebo-controlled trial for outpatients with mild to moderate COVID-19. Treatment for this participants were initiated within 3 days of a positive SARS-CoV test that's running through the studies, and participants were randomized to receive, 2 different doses of the combination therapy or placebo. Now, in this study, this is an interim analysis just to highlight that obviously they're looking at changes in viral load over time, and this is the data shown in the figure above is what happened over a 7-day period with virologic monitoring at baseline, day 3, day 5, and day 7. And you can clearly see a little bit of difference between those who had serum antibodies at baseline, those who were serum antibody positive, and those who were negative. So there was significant declines in individuals who did not have their own antibodies prior to receiving the infusions as against those who did. On their interim analysis, regardless, composite, at day 28, and this is, again, not peer-reviewed, but as presented in their EUA data, and this included much more participants than in the above figure, which was about 275 participants, but among 434 participants who received either dose of karkyr and devimap, the event rate, which is hospitalization and emergency room visit within 28 days of treatment, was 2%, as against 4% in those that received placebo. So again, across all the studies, you see that the monoclonal antibodies within the outpatient setting for people who are more recently diagnosed with SARS-CoV-2 tend to have quite significant impact on decreasing rates of hospitalizations, and the virologic data is a little all over the place. So that was for treatment. There was interesting data presented at CROI as well for monoclonal antibodies for prevention. And so this was one of those studies that looked at bambalanivam for patients in nursing home settings. And so the study design was there's a confirmed case at site, and within a 7-day window, they evaluate contacts and one-to-one randomization to bambalanivam or placebo. And again, participants, just to shorten that timeline between identifying contacts and getting them on study, they enrolled them prior to assessment of their baseline SARS-CoV-2 status. And so that allowed for 2 populations to emerge, those who would then be in the treatment population as against those who would be truly, like a post-exposure prophylaxis approach. So the primary outcome here was symptomatic lab confirmed COVID-19, but there was also secondary outcomes, which are SARS-CoV-2 infection. So they could also even comment on, viral load positivity. And for the group that were in the prevention population, as shown in the results, these were the subset of individuals who were negative for SARS-CoV-2, so they didn't have active, at least were not carrying virus, and did not have antibody tests, so they didn't have a past history or recent history of COVID. And so the results were quite striking, and you can see in the figure above that for when looking at the residents with symptomatic COVID, and this is the prevention population, again, these were people who were SARS-CoV-2 PCR negative, you can clearly see that there were much lower rates of COVID-19, symptomatic COVID-19 in those who received BAM compared to placebo. The prevention was, there was an up to an 80% reduction in risk among that group. And we can see that there were no deaths due to COVID-19 in those with bambalanivam. There were also studies looking at viral loads in individuals who had breakthrough infections, and it was found that those who received BAM tended to have lower viral loads. And we know there's a lot of interest on some of these agents also being able to block transmission. So all in all, in the interim results, looked quite promising and effective as prophylactic agent for individuals who were exposed. And they found this both in the prevention cohort. They also had a high-risk cohort as well. Then there was also data for the MABs for prevention at CROI. This was Regen-CoV. This is karkyr and devimap. These were also interim results presented at CROI. The studies of phase 3 randomized controlled trials involving adults and kids, but kids are not included in this current analysis. And how it is that if there's a household, if there's a case, they assessed household contacts of that case, enrolled them within 96 hours, and again assessed for those who were PCR positive and negative at baseline and enrolled them in separate cohorts. And so for those who were PCR, so they enrolled people who were PCR negative, with the endpoint being having a PCR positive SARS-CoV-2 infection, whether it be a symptomatic disease or asymptomatic disease. So they looked at the composite, but also looked at those who had symptomatic disease. And so in this study, they found that compared to placebo, there were no cases of symptomatic PCR positive infection, so symptomatic COVID-19 in individuals who got REGEN-COV or azevimab and devimap than those who got placebo. Now, when you looked at the composite of those who had PCR positive infection, whether it be symptomatic or asymptomatic, you can see that there was at least a 51% lower odds of having positive PCR, so probably driven by asymptomatic infections in individuals who received REGEN-COV. So, put together, it showed that the antibody cocktail prevented symptomatic PCR positive disease. It reduced infection rates, and even for those who had virus post-drug, appear to have decreased viral loads and even duration of viral detection or shedding, which is very reassuring. So I know one of the concerns with the monoclonal antibodies, obviously, is that how well the slides go with the variants that are currently circulating. I think we just saw news today that the B.1.1.7 is now emerging as the dominant strain all through many parts of the US, of the UK origin. And also, other, circulating variants like the B.1.351 and P1, which are really not a big problem for us as of yet, as well as our own homegrown variants, the B.1.42749 identified in California and the B.1.526 in New York. And so the different constructs, remember, lots of these are in vitro assays, so different constructs of virus-based or pseudovirus-based on the different mutation combinations. So if you look at the key mutations tested, they're listed with the acronyms for the different monoclonal antibodies and the specific mutation within those strains. And so for bambalanivam, you can see for the B.1.1.7, there's no fold change, no fold reduction in susceptibility. But for, the P1, California, New York variants, there was a significant fold reduction that impacts susceptibility to that monoclonal. For the combination of BAM and it, there's, again, the B.1.1.7 did not show significant impact on did not show any significant impact on susceptibility to that. But then you can see that for the P1 and 351, there appears to be quite significant reduction in susceptibility. And the CAS-IMDEV looked really good with really no change in fold reduction in susceptibility for that particular combination. Now, again, just really want to mention that these are in vitro data and not real world data. And so we need to just take that with the caveats that come with those. One other new agent, now moving on to new agents that are exciting, is VR7871, which is a GSK monoclonal antibody. It's an anti-SARS-CoV-2 monoclonal antibody that targets a conserved epitope of the spike receptor binding domain. It's quite promising. In vitro, it neutralizes not just wild type, but also pseudotyped viruses that harbor mutations similar to the B.1.1.7, B.1.351, as well as P1, so which is fascinating. There are mutations that can evade this monoclonal antibody, but it's thought that 99.99% of sequenced virus in the US would remain susceptible to this drug. So it's really promising. So in the phase 3 COMET trial, which is ongoing, again, another outpatient study of a MAB looking at mild to moderate COVID-19 for individuals at high risk of hospitalization, where individuals were giving this monoclonal compared to placebo, they found an 85% reduction in hospitalization or death compared to placebo. Again, this is just limited information we have available, but again, looks really promising. And I think really because of the relative fact that it's relative to the variants that are circulating, that this is a promising product. There's also a combination BAM VIR 7871 study, and preliminary data suggests that it's associated with a greater reduction in the viral load than placebo in low-risk adults. So going back to the audience response question, so we've seen that BAM is really knocked out by everything that's not B117. Again, we showed studies in outpatients. I didn't show you any of the patients in hospitalized patients, but we know that many of these monoclonal antibody studies have shown no benefit within hospitalized patients, and many studies have been terminated prematurely. And in the Active trial, that was another trial where BAM actually did not show any impact on clinical outcomes. Casirivimab and imdevimab bind to non-overlapping epitopes of SARS-CoV-2. And that's one of the strengths of those combinations, so that they are independently less vulnerable to mutations that knock out the other. And outpatient studies of SARS-CoV-2, I think we've seen that viral load trajectories are all over the place. And in some cases, even where viral loads don't change much, there have been sometimes observed positive clinical outcomes in spite of the viral load trajectories. So I couldn't end and couldn't resist without talking about one of the real buzzers that's really getting a lot of press, which is molnupiravir. And so this is, a study from Nature that looked at its effect of SARS-CoV-2 transmission in ferrets. Molnupiravir has a broad spectrum activity. It's a nucleoside, and that has activity against many RNA viruses, including a range of coronaviruses, and apparently in viruses that could be resistant to remdesivir, which would be a competitor antiviral. It inhibits viral replication, causes an error catastrophe. The advantage is an oral agent that's dosed twice a day. And this is a phase 2 and 3 trial that's going on in both hospitalized. There's phase 2 and 3 trials going on in humans, but this is the animal study. We'll talk about the human trials shortly after. What I thought was fascinating was that there are 2 experiments here. So one is looking at 3 different doses of the molnupiravir compared to a vehicle, which is an inert placebo. And if you look at the different doses, even for the doses of molnupiravir, there were the 5 and 15 were dosed 12 hours post-infection, and then in the red was given 36 hours post-infection. And you can see that the viral load really goes down quickly within 2 days for the lower doses that were given 12-hour infection, 36 hours, there's a little bit of a lag. But compared to those who got a vehicle, you can see significant differences with just the virologic decay in those who got the drug. Okay, so preventing establishment of infection post-exposure. And then also they did another experiment, which was interesting. This was a nasal lavage for SARS-CoV-2 virus. And this was just simulating what happens with transmission. So they would infect a ferret and then house it with other ferrets. And the goal was to see what happened to the co-housed animals who were exposed to infected animals, both those that were treated and not treated. And interestingly, again, if you look at the black, there is the source ferret, the contact ferret, about a day later, those co-housed with them had significant numbers of virus recovered. But for the contact ferrets that received molnupiravir, for the contact ferrets of the source ferrets that were treated with molnupiravir, you can see that there were no infections. So suggesting that if you treat an infected animal, that they were less likely to transmit to the animals that they were co-housed with, as a proof of concept. And so at CROI, this was virologic data presented by Wendy Painter from the company that makes the drug. And so this looked at an infectious SARS-CoV-2 virus in a treatment study of COVID-19 among non-hospitalized patients. So they had to be within 7 days of laboratory confirmed COVID-19, and they were randomized to oral molnupiravir, different doses versus placebo, with nasopharyngeal swabs collected over time, day 3 all through day 28. Interestingly, they also cultured the virus and then PCR'd it afterwards so that they could also comment on isolation of infectious virus, which I thought was a strength of the study. So what the data was that the proportion of participants with positive viral load by culture were significantly different both at day 3, post-study entry, and day 5 for all individuals, with about only 20% of people who received molnupiravir as compared to 28%, although that wasn't clinically significant, having a positive viral culture with a positive viral culture. And at day 5, no patients who got any of the molnupiravir doses had a culturable virus that could be detected by PCR. So this really showed, quite robust virologic efficacy in people who received molnupiravir. So I guess we will be hearing a little bit more about this agent in the future. So back to our treatment guidelines again, I think that, having gone through the data, we can see that, the evidence has really dictated the recommendations around what could be used and what shouldn't be used. And I'll just really end by saying that, clinical trials have really helped define what are effective treatments for COVID-19, which patient populations benefit most, and at what point along the disease course these therapies work best. We know within hospitalized patients that, for those with mild disease who are not requiring any oxygen, I think there's openings there. We're catch a lot of these as outpatients, but for hospitalized patients who don't require oxygen, I think there's still a lot of work to be done. For those with serious or critical illness, are they too advanced in the disease syndrome for any of our therapies to really show that much benefit? I think is an open question, and I think these continue to energize the field to continue to find answers to these important questions. We've seen that combination antiviral immunomodulator therapies have shown some promise, and many more are undergoing an evaluation in clinicaltrials.gov. There's so many studies with remdesivir combination therapies and other combination approaches to try to evaluate their impact on patient outcomes. MABs have shown great promise in the outpatient setting. They haven't really done well in inpatient, and they work well as treatment and prevention. And combinations may be necessary to retain activity against the emerging variants. So I'll stop here. Thank you for having me, and we can move to Q&A.
Wow, thank you for that tour de force. Your mastery is amazing. We actually are running short of time. I'm going to pick one representative question and then ask you if you wouldn't mind answering the questions directly, because there are quite a few that are very specific. One individual asked whether you have any comments on the double mutant variant and potential efficacy of treatment.
Yeah, so I think we all saw that data, right, about a variant that had combination mutations that we hadn't seen before in a single strain, I think is the question that's being asked. Again, that's why, some of the data on which mutations impact the different monoclonal antibodies has become important and should continue as new variants emerge. But I think the message here is that combination monoclonal antibodies, I think, is the answer to many of these variants. And combinations that have different sites of action, non-overlapping targets, I think is the way to go.
Okay. Well, thank you very much. That was really exciting. And I think we'll turn back to our moderators to close down the session.